thank you everybody for this invitation. I've been involved with the care of VHL patients for about a decade now, since I arrived at the NIH Clinical Center, and this is an opportunity to share some of that work and also to share some new things, some new findings, and where we are headed in that general direction. So I'm a surgeon by training, a neurosurgeon, and I do take care of a number of patients with the von Hippel-Lindau disease, specifically the ones that present with hemangioblastomas. I work at the clinical center, NIH Clinical Center, which is in Bethesda, Maryland, and we run a natural history study that allows us to to evaluate patients, not just from the United States, but also from other countries as well. Now, the program, the VHL program at the NIH, there's a long history for it, as Dr. Linehan, has shown so elegantly. Dr. Linehan and late Dr. Edward Oldfield were essentially pioneers and my senior mentors in this journey, followed by Dr. Russell Lancer, who taught me a lot of the surgical techniques that are required for taking care of our patients with VHL. And I continue working with Dr. Mark Ball from urology and Dr. Chu and a lot of other members, that all of whom help us take care of the VHL patients as a patient and not just looking at a single tumor or a single organ system. But today I would like to focus on the central nervous system manifestations of von Hippel-Lindau disease. These are the ones that we deal with in my clinical practice here as a neurosurgeon. Now, primarily, we are dealing with hemangioblastoma. These are tumors that are benign, but they can cause problems. And we'll talk about what they are and why they need to be addressed. But one of the things that we need to learn pretty early on is it's not cancer. And fortunately, neither is the second central nervous system tumor that we deal with, which is endolymphatic sac tumor. That's not cancer either, and it's not supposed to be. But by cancer, I want to really define the term here for all of the members that are in the in this meeting, is we don't see evidence of metastatic disease. So if you find a hemangioblastoma and if you're able to remove that completely, we don't think that this is going to come back. We don't think that these cells will go and embed in some other place. If you do have another hemangioblastoma, that's an entirely new phenomenon. So I just wanted to be very clear about that. Now, the experience with von Hippel-Lindau disease at the NIH Clinical Center is informed by this large natural history study of VHL patients with hemangioblastomas that we've been running since the year 2001. Now, although we're not recruiting any new subjects to this study, but we still see patients within and outside the trial through different trials that allow us to see patients from around the world, specifically patients with problems in the central nervous system that arise from VHL. And if they need surgery, we're able to offer that through a different trial. But this is the wellspring of knowledge for hemangioblastomas and how to manage them. And this is the trial that has taught us the most over the last 30 years or so. Now, what are the lessons that we learned? In the management of neurosurgical management of von Hippel-Lindau disease, one of the key lessons that we've learned is that hemangioblastoma growth can be saltatory. The growth patterns are stochastic, they're essentially random. We can't predict which tumor, we can't predict with a great degree of certainty which is that tumor that's going to cause problem during the lifetime of a patient. And part of the reason why that happens, we think, is because sometimes tumor will grow for a little bit, then they'll stay quiescent for a little bit, then they'll grow again, and then they'll stay quiescent for a little bit. So that means, that leads us to the second point that arises from that, which means, the key lesson number 2 is that size doesn't matter. Unlike urology, where 3 centimeters is a cutoff, and other instances of other organ systems being involved, size really doesn't matter for us as neurosurgeons taking care of our patients with VHL. What really matters is symptomatology. Now, symptoms are very varied depending on where the hemangioblastoma is and if the hemangioblastoma is growing. So for instance, the most common hemangioblastoma that we see is in the cerebellum. And the most common reason patients present to us with symptoms from an active tumor is headache, which is about 77% of the lesions that ever needed surgery. And then, of course, there's balance problems and nausea and vomiting, et cetera. Now, if you look at other locations, for instance, if you look at Chittiboina, which is at the bottom of the spinal cord, now urinary and bowel abnormalities are the ones that the patients present with, and sometimes pain and dysesthesias and paresthesias. So it really depends. So we need to have a very good understanding of the neurology catechism, which is the same as the catechism for real estate, which is location, location, location. So really what we really want to know is what is the location of that tumor, and could that location be attributable to some of the symptoms that our patients are presenting with? Because if it's not symptoms, then we just don't operate by looking at the tumor growth or just the tumor volume. That's because that's key lesson number 3. Because what we have seen is if we just went with imaging evidence of growth, and if we had operated on that, rather than waiting for the symptoms, we believe in our analysis that each of our patients will receive approximately 4 additional surgeries for every 10 years of their lives. So what we've learned is perseverance and patience in managing our patients with von Hippel-Lindau disease, and and just wait for the symptoms to occur, because there is a small chance that even though the tumor was growing quite quickly, it may just stop at that point because of the stochastic growth patterns. So really, these are the big key 3 key lessons that we have learned. Now, unfortunately, some of our patients do need surgery from VHL, and we do offer a very high level of care for our patients with VHL. This is just a snapshot over the last 10 years. We've approximately performed 370 surgeries for CNS manifestations of von Hippel-Lindau disease. That include a vast majority of them are hemangioblastomas, as you can see here. And they're essentially found in the cerebellum. Some of them are found in the spinal cord regions as well, mostly in the cervical, some in the thoracic, and very few in the lumbar territory. Now, we also see endolymphatic sac tumors here. Over the last 10 years, we've seen approximately 7 or 8. And then we've seen some rare tumors such as microcystic adenomas. So this is the spread of these tumors. Now, we've also learned a lot from performing surgeries and providing surgical before and after care for some of the patients. And again, the things that we've learned is that we don't want to intervene until symptoms occur, but then we want to understand, well, what is the cause of those symptoms? And what we have realized is essentially one thing, which is volume effect. And the volume of the tumor or the volume effect could be modified by either tumor growth, swelling in the surrounding brain, or cyst formation in the surrounding brain, really. And when we chart out how these volume changes affect the pressure, really there's a sharp line that determines when our patients will become symptomatic from either the tumor growth or swelling or cyst, because at that point there's a critical displacement of the normal brain and spinal cord structures that leads to a exponential rise in the intracranial or intraspinal pressure. Now, these are some examples of how we've seen our patients progress. This is just an example of tumor growth. We've seen over, in this region of the cerebellum, we've seen that the tumors were relatively stable until 2018, and then suddenly there was a big growth in these tumors at the bottom at the caudal end of the cerebellum that led to the necessity for intervention because the patient presented with severe headaches and gait abnormalities and gait ataxia. And of course, when we did the imaging, we found that these tumors had just taken off in size over the last year. So this is a classic example of how tumors will present with growth. Now, the other reason why tumors will present with symptoms would be because of cysts. Now, this is a tumor, again, on the left side of the cerebellum within the hemisphere. We can see that over 2 years, there's been the formation of a small cyst. And we think that the cysts form because the blood vessels, the endothelium of the tumors is quite leaky, and that allows for a lot of exudate to escape into the surrounding tissue. Now, that surrounding tissue could be brain, brainstem, or spinal cord. And when the volume and flow of this exudate exceeds the level of the brain or spinal cord to absorb it, that's when we have the formation of a cyst, or it can be called a pseudocyst because it's not really lined by a columnar epithelium or a cuboidal epithelium. And these cysts, unfortunately, tend to grow at a very, very rapid clip. So you can see over the span of 1 year, there had been a sudden increase in the growth of the tumor, of the cyst, while the tumor essentially remained the same size. So this is the second reason why we feel, why our patients present with symptomatic manifestations from CNS hemangioblastomas. Now, we have seen evidence of cysts preceded by quite a massive increase in the edema around the tumors. And in some patients, edema itself can lead to changes in the intracranial pressure and the need for surgery. So the patients can present with symptoms just because of raised pressure when there is a significant amount of edema or increase in edema around even a small hemangioblastoma. So that's really the third reason that we've seen that our patients end up needing surgery. And then, of course, there are some atypical presentations. We can have large cysts formed within the tumor. We can have renal cell cancer metastasize to the hemangioblastoma because it finds a favorable bed. Now, those are some really other reasons. Now, well, what does happen when our patients need surgery? What we've learned is there are some key surgical principles that allow us to then take care of patients with very large and otherwise considered inaccessible tumor. For instance, this case of a very, very large brainstem hemangioblastoma, which is by any means considered to be a fairly dangerous place to perform surgery. But the surgical techniques that we've learned and perfected over the years allow us to approach this in a careful manner, in a planned fashion, by performing porosectomies or approaches through the spinal cord and through the brainstem using the safe corridors. And once we have the safe corridor to the hemangioblastoma, the next key principle is really to stay on the surface of the tumor. This is not a tumor that lends itself to any sort of debulking. We have to stay entirely on the outside of the tumor. We have to completely surround the tumor by our dissection and gently move the normal brain or spinal cord or brainstem structures around. And as we get around it, then we see the whole volume of the tumor emerging from the surgical cavity. The reason why we feel that we have to stay on the outside of the tumor is, as we can all see, that these are very, very vascular tumors. And any entry into the tumor leads to quite a significant amount of bleeding that makes our surgery extremely challenging. So we can see that we are cutting, we are cauterizing and then gently cutting those very, very small feeder blood vessels that the tumor starts gaining from the surrounding brain or the brainstem. So this is the kind of surgical technique that allows us to then isolate the tumor from really major blood vessels, which could be spinal artery in this case, or could be other major blood vessels, and allow us to completely take the tumor out as one piece. And this is really the key principle that we've learned really over the years. And we adapt our surgical strategy to the given tumor. For instance, here we had to use motor evoked potentials to make sure that the connection, that the signals were traversing through the spinal cord and the brainstem. Now, we've also learned over the years how to operate safely within the optic apparatus, including the optic nerve and the chiasm, and while preserving the vision as well. And we've learned over the years how to recognize which is that lesion which is resulting in this severe syrinx, which is essentially cysts all the way up and down the spinal cord. So these are some of the strategies that we've learned. Some other key lessons that we've learned with von Hippel-Lindau disease related endolymphatic sac tumors what are the reasons why our patients lose hearing in those patients that do present with these rare tumors of endolymphatic sac tumor. That could be because of the large amount of tumor growth and invasion of the auditory structures, or it could be because of hemorrhages in the intralabyrinthine system, or just collection of fluid or endolymphatic hydrops. So we have also learned how to try to preserve hearing by removing very, very small tumors that could be the source of intralabyrinthine hemorrhages in our patients. And we've also dealt with very rare VHL-related CNS tumors, including microcystic adenomas as well. Now, we have found that over the years, natural history studies such as this here at the NIH have really informed a lot of the science that we do. We were able to investigate what are the factors that change with the loss of quiescence. In other words, if there's a tumor, if there are two tumors and one of them is growing and causing a cyst while other is not, what could be related to that? And we saw an autocrine paracrine effect along the erythropoietin pathway that was likely to be responsible and could separate the quiescent hemangioblastomas from symptomatic hemangioblastomas. In addition, we have found the expression of somatostatin receptors very highly in our hemangioblastomas that is leading and opening some new doors in trying to address these central nervous system hemangioblastomas with somatostatin analogs. So stay tuned for that. And then we've also recently found that there could be a potential role for a very cheap off-label use of a very cheap drug such as propranolol for an off-label use to control central nervous system hemangioblastomas. Now, most recently, we have completed a trial where we specifically looked at our patients that carry about 30 to 39% of them carry germline missense mutations, and we asked whether we can really change the level of the VHL protein and rescue the VHL protein by abrogating the protein degradation in tumors, and we found exciting evidence that this could be a potential pathway that could be added on maybe to strategies such as belzutifan. And so this is a work that is just sent out for publication, and we're hoping to get it out this year so that our community can really learn from our experience in this small window of opportunity clinical trial. And going towards the future, in the next few minutes, I'd like to talk about where we are headed with all of this data and experience. One of the things that we really wanted to address was, is there a way to design our clinical trials by picking a target tumor for hemangioblastoma and calling it a target tumor, and then asking whether this drug or whether this intervention that we are giving our patients, is it actually helping or not? And part of the reason why this is such a challenge is because of stochasticity or the randomness of the growth patterns. But when we looked at our overall experience and we isolated approximately over 1,000 cerebellar hemangioblastomas and saw these patients over 13,000 visits. So most of these patients we have seen many times over the span of 10 years. And we have serial data about imaging from that. And then we applied an algorithm. That algorithm comprised of these two formulae, which is if a cerebellar hemangioblastoma is greater than 100 cubic millimeters and has had a 20% volume increase in the last year, we believe that we have identified these tumors as high-risk tumors because these are the tumors most likely in the coming years to progress in size and also most likely to cause symptoms in the coming years. So this is something that we believe we can use data to provide to the regulators, as well as data to provide as controls for upcoming clinical trials, especially the trials that are targeting hemangioblastomas in the cerebellum. Now, there are two questions which we are hoping to answer in the near future or in the coming future. One of them is, do we need contrast really for surveillance imaging of central nervous system hemangioblastomas? And I can tell you over the years, I'm not really sure that we need contrast because now with modern MRI imaging, specifically non-contrast DFFE imaging or even T2 weighted imaging, we can clearly see the cysts, we can see the tumors, we can see edema. This is something that we are evaluating very, very carefully because this could really spare our patients repeated exposure to gadolinium, which has shown to have some long-term health detriments. And then the second question that arises from that is even a little more heretical. That is, do our patients really need surveillance imaging? And I would just like to, say that we're not ready to do this yet, but this is something that we're asking ourselves, because what we have realized is even if we follow our patients every year with routine imaging, whether it's with contrast or without contrast, when our patients call us and say that they have new symptoms, and these are the ones that need surgery, we realize that 80% of them do end up needing a new MRI of the brain and spine anyway. So this is something that we'd like to carefully evaluate in a stepwise fashion. First, do they need gadolinium? Do all of our patients need gadolinium? And number two, do all of our patients need yearly scans? So we don't really have answers, but we're hoping to get there sometime soon. One thing I'd like to add is, the landscape has significantly changed with the addition of belzutifan as a clinically approved drug. And what we have seen is, on an average, about 30 to 40 patients with VHL were needing surgery at the NIH Clinical Center. And over the last year, it's been halved down to 20. A few of these patients have been exposed to belzutifan, but a few of these patients come from other countries, for instance, Canada and some low and middle resource countries. So we're happy to provide a service, and I'm happy to take questions. This is my large team that helps me take care of our patients with VHL and other syndromic tumors, such as NF2, and we're here to help.
Great, thank you, Prashant. Wonderful, and it really piggybacks on Andrew's patient corner, where he was talking about his journey with multiple laminectomies. So thank you for that. So I think I have one question in the chat. Where are posterior hemangioblastomas in all likelihood inoperable and SRS radiostatic surgery undertaken? Would you consider embolization to hinder and prevent tumor rejuvenation? So presumably, if there's no surgical or radiotherapy option, would you consider embolization? What
we have seen, we haven't really embolized hemangioblastomas, because the problem is hemangioblastomas really take parasitized blood vessels from the surrounding tissues. And by the time, so appropriate embolization of hemangioblastomas is not considered to be feasible. We have embolized a number of endolymphatic sac tumors, though. That's a whole different ballgame, because that really allows us to take the tumors out in a safe and relatively bloodless manner. But for hemangioblastomas, we have not considered embolization to be a valid strategy because of the way the tumor derives its blood supply from the surrounding tissues. Now, radiation itself, I think, there are some patients that we have really no options but to recommend radiation. But over the years, they have not been many. And part of the challenge with radiation, as most of us know, is the smaller the tumor is, or the smaller the tumor remnant is, the better the radiation works. And if a tumor has not been removed by surgery or attempted removal by surgery, then we're not really sure about the effects of radiation in overall longer-term growth patterns. Great. Othan for a verbal question. Go ahead, Othan.
Yes, hi. Thanks, Raymond. Good morning. Hi, Prashant. Nice to see you. I mean, wonderful talk. Thank you very much. As you know, we have a hemangioblastoma center over here with the MGH, and we talk to you guys very often, your neurosurgery colleagues. We go over 20 years of collecting the same data. I appreciated very much the way you put it. I would beg to differ in something here, and I think that this is a very subtle, probably difference, but with big consequences. Size doesn't matter. I agree. Location matters, I agree, but I think that there is something else that we may need to put forward, and I want to hear your thoughts about it. I think that what matters the most is growth rate. It's exactly what you presented later on, that once you pass a point that you become symptomatic, the growth or the symptoms may be accelerated. So the effort that we make here is to, if we see moving on the tumor, we have a little bit more frequent imaging so that we know if the tumor is going to hibernate again in this kind of broken line that you presented, or if it's going to have a linear growth. Our neurosurgeons here tell me that they like to see these patients before they are symptomatic, when the cyst or the tumor is growing, not slowly. So it takes a lot of clinical experience and judgment. Is this guy going to give me a problem in 3 months or not? And I want to hear your thought here, because I don't want the audience, I mean, at least my opinion, to go away with the feeling, if you don't have a headache, don't bother. And if you have a headache, call your neurosurgeon.
So I think you really hit the nail on the head here, and basically giving me a headache, So no,
call your neurosurgeon.
Yes, no. So I think you raise a very, very interesting point, and it's very subtle. And thank you for bringing that to the forefront here. So there are two things that I'd like to say about the stochasticity or the inability to predict the growth patterns. There are two things. One is that's over long periods of time. And the second is over a large range of tumor sizes. So I just want to be very clear. But when we start looking at our patients, we've seen these patterns over and over and over again. There's a patient who for 4 years had this cerebellar hemangioblastoma that was the same size. And now over the last year, it has suddenly grown. And now we're like, okay, what is this going to do? Let's bring this patient back in 3 months or even 2 months, and let's. So yes, you're absolutely right. Gestalt is absolutely, and this is exactly what we were trying to get at. And this is why I think what we did was we did a range contraction. We said, we're not going to ask this question over all of the tumor sizes and all of the, the entire lifetime of the patient or the lifetime of that tumor. But what if we asked if the tumor had a certain threshold size and a threshold growth rate? Does that predict? And yes, I think that's where really we are starting to see this ability to predict the future growth patterns. And you're absolutely right. But unfortunately, we only have very strong data for cerebellar hemangioblastomas yet. We're still looking at the other brainstem and spinal cord. The problem with those is, as you know very well, a tumor that's quite small in the cervical region can cause symptoms, while a larger tumor in the lumbar may not cause symptoms. So there are some challenges in interpreting that data.
Maybe the volumetrics from the spine should be different than the volumetrics for the cerebellum.
You're absolutely right, and that is the right approach.
Very, very happy that we agree on this. Yes, we're on the same
absolutely.
Thank you, Prashant.
Thanks, Othan. In the last couple of minutes, Prashant, I wanted to see if you can address a couple of questions in the chat. They might be related to the stochastic question that Othan had mentioned. One is from Franco, are the clinical images showed on a public database? Are those available anywhere?
Not because we are a federal government institution. We have not really, published the database yet. I'm not, because of HIPAA regulations and all of that. So no, these are not public database, but these are available for internal use within the NIH Clinical Center.
Okay. And then do you observe saltatory growth patterns also in CNS cysts or only in tumors?
Yes, both tumors and cysts. But again, just to qualify that statement, over long periods of time and over a large range of sizes.
Okay, and the last question is vorinostat an effective agent to treat CNS hemangioblastomas?
We don't have a full answer to that. The question that we asked with our trial was very limited. It was a window of opportunity trial. The question that we were asking was, does the biology make sense? And the biology did make sense. In our hands, we think that in those patients that received vorinostat for about 7 days or so, we clearly showed by comparing their own tumors from a different epoch that we were able to rescue the VHL protein. And that's exactly what that was the question that we were asking. Now, there's strong data that supports the use as a longer term agent, but we don't have direct evidence for that.
Okay, well, thank you, Prashant.